Hello. How are you, Mo?
I'm okay. How are you? Oh, hi. I'm so tired. Exhausted. How are you? Surviving. Are you IMT too? Or one more. What's your name? Abed. Abed. Oh, nice to meet you. My name's Mohammed. Oh, that's it. I haven't met you before. I'm usually on Teams. Oh, okay, you don't come. If the teaching is here, I do. But that's not okay. It's always in the. Yeah. No one really comes. Like I would say yesterday, literally, it was just me and Emma. Like, no, last week. Sorry. Yeah.
Last week was the MRC.
Oh, okay. Yeah.
It was a good session, though.
It was good, yeah. It was rheumatology. It was good, yeah. I'm usually on Teams with. That's it.
It's only 3 of you. How are you coping?
Surviving.
Surviving, yeah. Just about.
Still surviving. Not survive. I think you sent an email to the-
Yeah, I sent it yesterday, yeah. Thank you for your reply.
That should be fine.
Yeah. Is there like a list of things that the learning of degree because
Yeah, you do 9.
usually like in other trusts, ALS is always.
No, no, keep.
So I'm surprised. Thank you. Thank you for your reply.
I'm doing Saturday, Sunday during the day. I'm calling on the computer. I was 405. So, yeah, same. My house.
After the 4 lectures, for some reason, I wasn't able to switch.
Yeah.
Can I see how many people are on the team?
So if you go on Teams,
When was the MRCP?
It was last Wednesday. So, you know the very condition I told you Wednesday, morning on Friday. So I thought it over the weekend.
Yeah, it's really difficult to switch back.
So I didn't get switched. I tried to buy mandatory. People are like, we don't sell it.
Well, enhanced students,
But it's sharing.
what's really good is I take night nurse. So night nurse is like it has recommended in it. I always take it out.
So I got to
So part one or part two, by the way?
that was part 2 of last week.
You did part two last week. Good luck. How is it? Is it easier? Because mine's in March.
Wasn't easy. I think some very weird.
Is it harder than part one?
And yeah, I don't see any people from
But you think it's hard.
LinkedIn.
It's very different. I think part 1 is like.
Oh,
I
I was
so
also-
if you know it, you know it, you know it.
no,
It was
nobody from
really-
LinkedIn.
They should be time
Part
out.
2 is
Tracking runs.
Yes,
Decided
it's a
about
lot.
It's more clinical.
Yeah, sure says online, so.
Yeah.
And that's
That is
just
online.
trying to set up the link.
Really? What did you do for part two? Because I'm without stop preparing now. It's a lot. Yeah.
All of the classes.
Questions. It's way smaller. The question bank is way smaller than
Oh,
part
it
one.
takes long.
Oh,
The
really?
question stems are.
The whole page.
Presentations all about
Oh, really?
where is
Because when I looked at the question banks, 2006 question,
I know.
I was like, I was going through them like a month before.
That's what I
Because
thought.
part one, it was like 5,000 something questions. Like, no one was like,
Oh,
this
it's
one.
one shit. Takes much, and it's so much work. It's
Oh, really?
We actually choose to.
very
Is it the more sense? That's it.
I can see 3 doctors from Lincoln. Any more doctors joining?
I thought of you if there was a patient who tried to refer on one day, like the guy who had like a right-sided neck abscess, like a necrotic neck abscess, and it clearly said urgent ENT input, like the A&E rectal to refer to me. And I was like, no, I'm taking this patient, the surgical patient. And then they,
Oh, you guys were so.
No one's turned up at seminar room 4 at Lincoln, so you are free to start.
Okay, so we can start now, right?
Yep, you can go ahead and start.
Okay. So the not many doctors from Lincoln. Unfortunately, it's only 3 doctors, is it? Or what's happening?
So
Okay.
no one's turned up at Lincoln in person.
Okay, so that's very good, isn't it? Okay, so from Pilgrim, and I can see Mustafa, Shema, and that's it. So five doctors and 3 doctors from Lincoln. So altogether 8. So then I'll start the teaching. Can you see the slides?
Yes, doctor.
Yeah. Okay, right. So today, I was given this topic, generic curriculum. And, so it's basically something to do with research. So the topic itself is very boring. So so I'll try my best to explain this. But if you are not clear about this, and you can ask me at any time. So this is the topics that I'm going to cover today. So let's start with the literature search. So literature search is basically, it's a systematic and a well-organized search from the already published data to identify a breadth of good quality references on a specific topic. So when we do the literature search, and we have to follow the 6 steps. It's not moving. No.
Sorry.
Okay, so sorry, initially the slides are not moving properly. So now it's working, I think. So let's start with the literature search. So, as I explained, that this is a systematic and well-organized search from the already published data to identify a breadth of good quality references on a specific topic. So when we do the literature search, we have to follow 6 simple steps. So they are, number 1, you need to decide on your search question in your own words. The second step is define the terms and concepts. And you also need to use Boolean operators. I'll explain what it means later on. And you also need to limit your search and select the right database. And the last step is you start searching. So the first step when you formulate a research question, this and the step is a critical step and for good clinical research. So when you set up a research question, your research question should fulfill this criteria. Find is feasible, it should be interesting, it should be novel, ethical, and relevant. So we can use that model, PICO or PICOT model. So it is basically in your research question, and you need to include all these topics. So for example, research question is like this. Evaluate the effect of a certain drug, for example, lorazepam, for procedural sedation in daycare surgery patients. So you define the patients and you define the intervention. Intervention is basically to look at the effect of a certain drug. And you also compare. So some patients, and they don't receive the lorazepam, they just receive placebo. And you also look at the outcome. Outcome is an effect of that drug and in terms of sedation. So the second step in the research question, the literature search is define the terms and concepts. So when you do the terms, define the terms and concepts, and you need to break down the question into key topic areas, identify keywords, and include synonyms, phrases, and alternative spellings. So that's for example. When you put a search term, and if you want to search for old or older people, and you use the old, and after that, and put some sort of $ or asterisks, and so that when the machine search for you, it will search for old, older, old age, these sort of things. So this is another example. This is a research question. Discuss the closure of residential care homes for older people. And when you define the terms and concepts, and you can divide into three things: closure, care homes, oldest people. So these are your key search words. And if you use that sort of asterisks or $, and that will search all the relevant, literature, including these words: closure, settlement, patient transfer, and so on. So third step is use the Boolean operators. So Boolean operators means, and you use these sort of conjunction, or, and, or not. If you use the word or, and it will search everything. So it will search something to do with old and something to do with the another term. So if you use the word and it will search for only thing which is relevant to both terms. And you can also use the word not to exclude records containing the second term. So for example, if you use the word care homes, not United States, so that means, and the literature will search for all the care homes relevant literature, but not from the United States. So another thing is, and you also need to limit your search, otherwise you will get all sorts of nonsense information. So you can limit your search by using the language of publication, English only, publication type, year of publication, 2000 onwards, age group, and the country of origin. So these sort of things. So the next step is, and you also need to select the right database. There's so many databases, different databases, and you don't need to know about this, but if you need some sort of literature search for your research, and the library in Pilgrim Hospital, I'm sure the Lincoln County Hospital librarian, and they are willing to help you in terms of your literature search. So these are the usual database we use. So Medline, I think, and everybody is aware of Medline. So these are the useful sites and for your literature search. Google, PubMed, BSH. So another source of evidence-based database. So just to summarize, and in terms of literature search. So before you do the literature search, and you have to formulate a research question. And the research question should be final, and you can use that PICO or PICOT model. And after that, and you have to plan your search, and you have to use the important terms, and you can use the 3 or more terms, and you can also use the Boolean, the operators, and so that you limit your search. And after you have searched, and then you analyze on these, the literature findings. So this is about the literature search. The second topic I'm going to talk about is critical appraisal. So critical appraisal, as I said, and this topic is very boring. So if you have any questions and interim, and you can just ask me. So critical appraisal is a process of carefully and systematically examining research evidence to judge its trustworthiness. So after you have read about some sort of meta-analysis or literature review or things like that, then you need to judge yourself whether this literature you found is trustworthy. So to make that sort of judgment, the process is known as the critical appraisal. So, and these are the questions you need to ask yourself in critical appraisal. So number 1 question is, does this study address a certainly or clearly focused question? So does this the study answer your queries, answer your question? Number 2, did the study use valid methods to address this question? Number 3 is, are the valid results of the study important? And the last question you need to ask yourself is, are these results from the study applicable to your day-to-day life, to your patients, to your population? So these are the critical questions that you need to ask yourself. And when you do the critical appraisal for some sort of meta-analysis or systematic review or these sort of things. So let's talk about each and every type of literature. So you will come across at some point in your life and the systematic reviews. So when you do the critical appraisal on systematic reviews, you follow these 4 questions. So number 1, are these results from the review valid? So when you ask, and if it is valid, and you need to ask these questions specifically, does this review address your question? And is there any relevant studies missed? Were the criteria used to select articles appropriate or sufficiently valid? And after that, what were the results? You need to conclude yourself. And are these results important and applicable? So you also need to answer these questions by yourself. And this is more important, diagnostic accuracy studies. And when you do the critical appraisal of diagnostic accuracy studies, and you follow these 4 questions again, are they valid? And are they representative of the patients? Any reference standard and the test And also these findings are independent and blind. So this is also important. When you do the studies, particularly the diagnostic accuracy studies, and so there will be two groups. One group, for example, and if you're assessing the the effectiveness of a treatment, and one group they might not receive the treatment, they might receive the placebo, but you don't know which group received the treatment and which group received the placebo. It is called blindness. So the studies should be blinded, otherwise there will be bias. So when you look at the results of the diagnostic accuracy studies, and these are the things you need to look at. What is the sensitivity of the test? What is the specificity of the test? Positive predictive value and negative predictive value. And after that, you also need to make sure these test results are applicable to your day-to-day life. So I'll explain to you what these terms mean. I think you are already aware of these things. So let's look at a new diagnostic test for dementia. So, we do the study in 1,000 elderly people with suspected dementia. And all these the patients underwent the new test. And also they have a reference test. Reference test is the efficacy of the test that we already knew. But the index test is a new test that we are going to assess whether this test is applicable or not. So we know that the prevalence of dementia in this group is 25%. And so this is the result of these two tests. 240 people tested positive for both tests, and 600 people tested negative for both tests. So we can draw a conclusion like this. This is a reference standard test, and this is your index test. So index test and both positive is 240. So we know that the prevalence of dementia in this group is 25%. So we expect 250 patients to be positive and with the reference test. So 600 people tested negative with both tests. So this 600 is the two negatives. And we know that 750 patients will be tested negative because they don't have dementia. So what is sensitivity? So it is a proportion of patients with the condition who have a positive test result. So if you bring the previous table, so sensitivity means 250 divided by
240 divided by
2. So 240 divided by 250. So that is 96% or 0.96. So sensitivity tells us how well the test identifies people with the condition. So highly sensitive test will not miss many people. So that it is good for screening actually. And if the sensitivity is high, this test is good for screening. But it might not pick up the truly positive patients. What is specificity? It is a proportion of people without the condition who have a negative test results. So if you look at this, and it'll be 600 divided by 750 or 0.8. So specificity tells us how well the test identifies the condition. Highly specific test will not falsely identify many people as having the condition. So the better the specificity, the chance that we didn't pick up the false negative patients. So ideally, and then the best test is in the very high specificity and sensitivity. So this is the ideal situation. So what is positive predictive value? It is a proportion of people with a positive test who have the condition. So if you bring that table again, and the positive predicted value will be 240 divided by 390, or 62%. And this value tells us how well the test performs in this population. And negative predicted value is the proportion of people with a negative test who do not have the condition. So in this table, it'll be 600 divided by 610. And that negative predicted value is very high. So negative predicted value is good for excluding the condition. So you may have heard, the D-dimer test is has a very high negative predicted value. So that means negative D-dimer means it's very unlikely that the patient has the pulmonary embolism. So negative predicted value also tells how well the test performs in this population. And but they both depend on accuracy of the test and prevalence of the condition. So another study is the prognostic studies again, and so you need to follow these 4 things: RB and also the blind infection is better. And what were the results? So when you look at the outcomes studies, and there are so many different types, and they can present, and the outcome studies. And this is just an example. So this 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 is for disease A. The red dot is for disease B, and for disease C. So the endpoint is in 5 years' time. So whatever the disease, they reach to that endpoint, only 20% survive. And but their prognosis and over the period of 5 years is quite different from one disease to another. So this is one of the example how you can show the outcome of the prognostic studies. So another thing, randomized controlled trials. So, and you will also come across these sort of RCTs in your life. And when you critically appraise these sort of RCTs, and then you follow these same questions, are these results valid? Are these randomized properly? And are they blinded? Yeah, so these are the important questions that you need to look at. You need to answer your question, and you need to answer yourself. And after that, when we look at the results of the RCT, these are the main things that you need to look at. What is the relative risk? What is the absolute risk reduction? What is the relative risk reduction? What is the number needed to treat? So when you look at the RCT results, and you go on to look at the NNT, NNH. So and if you look at the efficacy of the new drug, and you look at the NNT, so the lower the NNT, the better. So I'll explain to you and how we look at it. So let's consider a study, and in which the finding is 15% of the control group and 10% of the treatment group died after 2 years of treatment. So what is then the relative risk? So relative risk is the risk of outcome in the treatment group divided by risk of outcome in the control group. So in this scenario, it'll be 10% divided by 15%, or it's a 2/3. So the relative risk is 0.67. So what does it mean? So the relative risk tells us how many times more likely it is that an event will occur in the treatment group relative to the control group. So that means that in the treatment group, and it's just a 2/3 of the control group. So relative risk of 1 means there is no difference between the two groups. If the relative risk is less than 1, that means then the treatment group is better than the control group. And if the relative risk is more than 1, this treatment is rubbish. You don't want to use it. Another thing you need to know is the absolute risk reduction. What does it mean? It is the risk of the outcome in the control group minus risk of the outcome in the treatment group. So if you remember these figures, control group is 15% and the treatment group is 10%. So it is the 15 minus 10, it's a 5%. That means an absolute risk reduction tells us the absolute difference in the rates of events between the two groups. So that means if you receive the treatment, so there's a 5% chance that you have a less, chance of dying. Another thing you need to look at is relative risk reduction. So relative risk reduction is basically the ratio between absolute risk reduction and the risk of the outcome in the control group. So in this case, it is 5% divided by 15%. So it's a 1/3. So, and you can also calculate relative risk reduction with this formula, 1 minus relative risk. So in this case, 1 minus 0.67. If you remember, what is the relative risk? So relative risk, is 0.67. So it's a 1 minus 0.67 or 0.33 or 33%. So it's the relative risk reduction. So relative risk reduction tells us the reduction in the rate of the outcome in the treatment group relative to that in the control group. So another thing you need to look at is number needed to treat, or NNT. So NNT is basically the inverse of the absolute risk reduction. So absolute risk reduction in this case is 0.05. So if you divide this to 1, and that'll give you 20. So that means, and to get the effect of this, the new treatment, to get the one outcome, and then you need to treat 20 patients at least. So if the number is high, so that means that it is not very useful. But if the number is low, and then that drug or the new treatment is useful. But then that sort of number, NNT, is actually good. So if you come across the new drug and the NNT 20, so that means that this drug is good. So NNT represents the number of patients we need to treat with the experimental therapy in order to prevent one bad outcome and incorporates the duration of the treatment. So there's another term, NNH. NNH is basically the side effect of the new treatments. So that new treatments, they might also have a side effect. How many patients were harmed during the study period? So this is the NNH. So NNH is basically inverse of the absolute risk increase. ARI is absolute risk increase. So NNH represents a number of individuals who must be treated so that one individual presents an adverse reaction countable to the treatment. So if the NNH is high, it is better. So it is something opposite to NNT. So if NNH is very low, and if you come across a new treatment with NNH of 4, so don't use that treatment. So this is a kind of a critical appraisal, isn't it? So when you read through the whatever literature, and then you need to think yourself critically, and to make sure these findings in the literature is useful to your day-to-day practice. So this is just the explanation of the other thing that I've explained. So there are so many other types of studies, qualitative studies. Again, we use the same for questions. Another study is individual patient data reviews. Again, we use the same questions. So the most important thing you need to ask yourself is whether these findings in these literature reviews valid, is it important, and also is it applicable to your patients? So these are the main questions you need to ask yourself. Okay, so that's all about the critical appraisal. Any questions so far? I hope, and the people at home, if they don't sleep. Mustafa, are you sure you are still awake?
I'm still here.
Okay, so the next topic and medical statistics. And medical statistics, again, it's application of statistics to medicine and health sciences, including epidemiology, public health, forensic medicine, clinical research. So it's a subspecialty of statistics, and it is basically science of summarizing, collecting, presenting, and interpreting data in medical practice, and using them to estimate the magnitude of associations and test hypotheses. So two main branch, descriptive statistics and inferential statistics. So descriptive statistics is basically, and it is something to do with description, distribution, and they don't draw any inferences. But inferential statistics is, and you make a conclusion, inference, and make a inference. So there are two different types of data, and actually it's a qualitative data and quantitative data. So qualitative data is, and you just look at what the color is, the things like that. You cannot measure in terms of numbers. That's a qualitative data. Quantitative data, basically, you can measure 1, 2, 3. And, you can represent in terms of numbers. So that's a quantitative data. And quantitative data, again, two different types: discrete and continuous. Discrete is, for example, age of the patient. So it's in one whole number. But then, for example, blood pressure, you cannot give a one number. There should be a range. So this is how we measure this central tendency. So mean, median, mode. I think everybody knows about this. So mean is basically average. The median is, and if you put the data in ordered sample, so that is the middle value. Median is the middle value. The mode is the most frequent value in a set of data. So this cartoon explains what is mean, median, mode. So mean is basically average. Median, if you arrange the data in the order, that is at the middle one. Mode is the most frequent. This is how we measure variability. So we can present data in range, interquartile range, and the standard deviation. So standard deviation is the average distance from the mean. So there is a specific formula how you can calculate the standard deviation. So the square of standard deviation is known as variance. This is then the interquartile range. And the data summary. And when you summarize the data, you can present in tabular form or graphical form. So I think that'll be useful for your audit presentation and things like that. So frequency distribution, and it is a graph or data set organized to show the frequency of occurrence of each possible outcome of repeatable events observed many times. So you can present and in terms of histogram. This is an you know that normal distribution, bell curve distribution. So if it is a normal distribution, usually, and you know the two standard deviations will reach in the 95% of the data. So, okay, so this is how you can present your data. Okay, so the next topic is study design. And if you want to do some sort of study, and then you have to, follow the study design. So there are different types of study design. So and it can be divided into that sort of cartoon. So this represents all the study designs, and we are using in medicine at the moment, medicine research at the moment. So the three main important questions we need to answer. So I'll explain it in next slide. So the first question is, what was the aim of the study? Is it to simply describe a population? So if it is the case, then it is a descriptive study. And or is it to quantify the relationship between the factors? And you analyze data. So it is an analytic study. The second question here is, and if it is an analytic study, and you need to ask this question: was the intervention randomly allocated? If it is randomized, that is experimental studies. For example, randomized control trials. These are randomized studies. If it is not randomized, it is just the observational studies or analytical studies. And under that umbrella, includes cohort study, cross-sectional studies, and the case control studies. So that the third question is, if it is the observational study, when were the outcomes determined? So what sort of point you are looking at? If you're looking back, so it is a retrospective study, sometime after exposure or intervention. So they have been exposed to some sort of risk and things like that. And you are looking from this side. So it is a retrospective study before the exposure. Sometime after the exposure, it is a prospective study and a cohort study. And is it at the same time as the exposure and intervention? So if it is a case, it is a cross-sectional study. So I think this will show you more clearly. So if you're looking just at the present time, it is a cross-sectional study. So if you're looking at the past, it is a retrospective study. And if you're looking ahead for the future, it's a prospective cohort or randomized control trials. And these sort of cohort studies, case control cohort studies can be either retrospective or prospective. So randomized control trials. So it is a study that randomly assigns similar people to groups to test a treatment, drug, or other intervention. So you get the study population and you divide into two, and it's just randomized and also blinded. So you don't know which patient falls in which group. Otherwise, if you know, and it'll make you biased. So to avoid bias, and you have to randomize. So and after that, the treatment group will receive the intervention, and the control group doesn't receive intervention, but they receive under some sort of placebo. And after that, you look at the outcome. So advantages of this randomized control trials is the bias is very minimal. And also randomization, if you do the very good randomization, the confounding factors and things like that, that will be very small. And after that, you can do the statistical analysis. But there are drawbacks. It is very expensive and time consuming. And they can still be a little bit biased, volunteer bias. And when you choose, these two groups should be similar to each other, age-wise, the sex-wise, these sort of things. So you have to randomize things carefully. Otherwise, and the treatment group will contain older people, and the control group will contain younger people. If this is the case, it is not a good randomization. Another study is a crossover design. So it is a type of experimental design where the same group of subjects receive multiple treatments in different sequences over multiple time periods. Again, you choose the study population, and after that, you randomize and divide into two groups. But the good thing is, and the better thing compared to RCT is, both groups receive the treatment. But the treatment and the order might be different. So this group and the first group received the green bit first, and then the red bit, and the second group red first, and then green. So, for example, and if you look at the cancer studies, and some group receives the radiotherapy before chemotherapy, and some group receives chemotherapy before radiotherapy, these sort of things. And after that, you compare the outcome. So, which sort of intervention is more efficient? So advantages of this is, again, they have own controls. Although the both groups receive the treatments, and these groups act like the control by itself, it's their own control. And the blinding is also possible, and the randomization is also achieved in this type of study design. Disadvantage is, again, it's a very time-consuming, lengthy, and also very costly. So another study design is a cohort study. So cohort study is a particular form of longitudinal study that samples a cohort, performing a cross-section at intervals through the time. So cohort study can be retrospective or prospective. So it depends on how you look at, where you look at. So this is an example. The patient has already exposed to a certain risk, and after that you look from here. And you can look back, and you can also look forward in the future. So it can be either the retrospective or prospective. Advantage, ethically safe, and we don't need randomization and things like that because we are just observing. And it is easier and cheaper than RCTs. But the drawback is it is not as good as, not as efficient as RCTs or the other studies. And in this case, blinding is very difficult. Randomization not possible. So another study is a case control study. So it is an observational study, and you look at what has happened in the past. So advantage is, and it is the only feasible method for very rare disorders. So very rare disorders, and you don't have many cases, many patients. So you look at these rare cases and what happened, and what did they receive for treatment, and what is the outcome of treatment. So this is the only study, and we can look at the rare diseases. So disadvantage, again, there can be bias, randomization is not possible, no blindness. These are the words you need to remember after this in the lecture. Randomization, bias, blindness. So when you read about RCTs and things like that, you need to ask this by yourself. So the next study is in cross-sectional survey. So cross-sectional survey is you look at the present time. So it's a type of observational study that analyzes data from a population, a representative subset at a specific point in time. So advantage is cheap and simple. You don't need to do anything. You just look at what's happening at the moment. That's it. Disadvantage, there are a lot of disadvantages, and there can be a lot of biases, and particularly that Lehman bias. So Lehman bias is also known as prevalence incidence bias. So just to explain to you what Lehman bias means. So if you look at the pneumonia patients, and you design your study, and I will look at the pneumonia patients who come to E&E during a certain period of time. So, and after that you study and you analyze the data. That might not represent the whole population with pneumonia. So some patients, and they're so severe that they died at home or nursing home or things like that. They don't come to hospital. So that is why it is known as prevalence incidence bias. So your study is only focusing on incidence, not the prevalence. So these are something about study design. So any questions? No?
No, doctor, thank you.
Okay. Thanks, Mustafa. You're proving that you are not sleeping. So that's good.
Yes, I'm not sleeping. I'm here.
Okay, so and next topic is evidence-based medicine. So Mustafa's just showed the evidence that he's not sleeping. So evidence-based medicine is a conscientious, explicit, and judicious use of current best evidence in making appropriate clinical decisions for the care of the individual patients. So it is also, described as process of systematically finding, appraising, and using results obtained from well-designed and conducted clinical research to optimize and apply clinical decision. So basically, when you want to do the research, the first thing is the research question, and after that you do the literature search, and after that you have to design your study, and after that you apply medical statistics, and then you analyze your data and the research findings. So, and after that, and they will decide, how relevant your findings are, and it's a kind of evidence-based medicine. So 5 steps in evidence-based medicine. Again, the clinical question, best evidence, critical appraisal, so these sort of things. And after that, you need to evaluate. So we can use this to design and prove knowledge again. And another important thing is the level of evidence. So you need to know what is the level of evidence. So this is very important. So particularly, and if you read the guidelines, so at the end of each and every paragraph, the guidelines says what is the level of evidence. Yeah, so you need to know what is the good level of evidence and what is the just a wishy-washy level of evidence. So this is the level of evidence used by SIGN guideline, Scottish. So that's published in 1999. And at that time, we used the 4 levels of evidence. So the smaller the number, the better the evidence. So later on in nearly 2011, this is another level of evidence published by Oxford. So at that level of evidence, they used the 5 levels, 1, 2, 3, 4, 5. Again, the smaller the number, the better the evidence. Okay, so if you look at this in the cartoon, the best, the literature you need to look at is the systematic reviews of all the RCTs. And there are so many different types of randomized control trials. And these control trials, so if it is on the same topic, they do the systematic review of all these RCTs. And evidence from that sort of systematic reviews is the best evidence. The worst evidence is just the expert opinions or your case series. It is not good evidence. And there's some people, they read the case report, and the case report says this. Oh, okay, so this will happen in our patient. It's not true. So case report finds something, but that might not be applicable to your patient. So that is why it is important to know, and when you read the literature, it is important to know what is the level of evidence. Is it trustworthy? Is it reliable? And this is another cartoon to show the level of evidence. So meta-analysis is at the top. Again. So, and I include this in the picture. It's because in some guidelines they don't see the level of evidence. They see what is the recommendation, grade of recommendations, particularly American guidelines. So American guidelines, this is the recommendation is A, B, C. So this is the equivalent to level of evidence. Again, expert opinions is at the bottom, and the systematic review of the randomized control trials is at the top. It is also known as a meta-analysis. Okay, so the last topic, and it's just for your knowledge. Research ethics. So 6 principles that should maximize the benefit to the patient and minimize the risk. Each and every individual in the research, their rights and dignity should be respected and maintained. And all should be on voluntary basis. You cannot force them to participate in the research. There should be integrity and transparency, and responsibility and accountability. And finally, there should be independence in research. You cannot rely on a drug company to fund the research. So if you rely on drug company, you will be biased with their. So that's why when you go to the conferences, when they are presenting their research, the first slide is disclaimer. So we've got the funding from this and that, but that will not affect our research. Okay. So I think, and it's all for today, but I hope and you get something. But if you don't get anything, I don't blame you, because any questions? This topic is very boring, and
It's very important when you get into research itself.
yeah. So if you want to do, particularly for the registrars, and they want to do some sort of PhD or something out of program for like 1 year, 2 years, 3 years, and they want to do research.
Yeah, I heard that they will ask you this at the specialty interviews.
Yeah.
In these stations, they have like critical.
What do you understand by critical comparison? And if you
I
want
think
to-
one station in specialty interview is critical appraisal of studies.
if you want
That was good then.
if you want the slides, I can share.
I think it depends if you're applying for an academic or not. It's for everything.
Everything.
That's good.
Dermatology as well. I know someone that
I've done a lot.
I think most specialties will have a bit of this sort of stations.
It was good.
Sure.
Okay, so any questions from Lincoln? Oh, looks like there are many people now. Any questions from Lincoln? I think they are Lincoln guys, isn't it? No.
No.
No questions, yeah? Okay. So that's fine. So yeah, we finished the teaching for today, and I think we can continue with the IMT forum. It is mainly for Pilgrim trainees, but if the Lincoln doctors want to stay in, and they can also stay in, it's not a problem. Okay, so shall we start the forum? Any problem? Any issues?
No, problems. I was just wondering, the end of rotation, you need a meeting, right?
Yeah.
With the supervisor. So do we just open up a form of education meeting? Is that
No, it's not an education meeting. It's the end of attachment.
Yeah, I can't open that form. Is it because it's not time yet?
No,
I think it's the
should be-
your supervisor does that.
should be able to open.
When you sit down with them, they open it, you fill them together, but they have their access to it.
Oh, I see.
I think.
Because I was on this account. How much home do we?
Wait, what? Google.
No, you cannot use them.
No, we were sitting together and she opened this account for me. And I couldn't find myself.
It's good.
It's so funny. Oh gosh. Doing something.
Endocrinology. But are you sure? Do you mind if I,
Just read.
so that then I can demonstrate. You go to the assessments actually. So go to assessments and click on forms, and after that you create form, and after that you can select end of attachment.
But that's from your account.
Yeah, or not from.
Yeah. It's called end of attachment. This is for the end of placement.
Yeah, so yes, the
Yeah.
same.
And there's an interim one, I think.
Interim reviews.
And the interim,
And the firm is coming.
which is
And also, if you want to do midpoint review, you can use that education. So ideally, and you should meet with your supervisor at the start of the rotation, end of rotation.
and also the
So end of rotation is the end of attachment appraisal, and the start of the rotation is induction appraisal. And also midpoint review, you can use education and meet to go on that.
and the interim is
You go through the portfolios.
Yeah, I'm showing the use the portfolio.
and that's done by education.
Yeah.
And the midpoint is.
I think you need to
It's a
do-
thing. And from it,
But just do, oh, so you do them for.
Just enter review how to use it.
No. Because I've never heard of it before.
Mustafa. I think Mustafa is.
You don't have to do it.
I'm sure there was two. There was, yeah. Yeah, I'm not keeping.
You sure? Is it? Have I put it on the YouTube, on the channel? I'm sure it's on there. But yeah, there's definitely.
There was definitely a session. There was
Yeah.
a session.
Do you hear? Do you hear what he said?
Yeah.
So you were
Okay, so any problem? Sure.
Just the portfolio, please.
So what about you? You're hoping with the before.
I'm just about open for
Just about.
yeah.
You will come across these. Yeah. So, I would like you to go for.
I've been thinking about 0.05 a lot, yeah. So I was supposed to 0.5
So
on
which
Monday.
one is which one is attending the crash course?
0.05.
Positive.
Yeah. I was supposed to 0.5 on Monday.
Okay, so no problem.
No.
Just a portfolio. That's good.
So I'm opening your portfolio.
That's mean I'm struggling.
So what can you study?
Well, I'm doing a lot of nights. Like I've done two lots of nights. So I found that to sign off an ACAT in night shift is particularly not great because you do a lot, not all the patients get a post take. And in the morning, some consultants do the post take by themselves, they don't call us. So that's why I've been to a lot of IF. That's mean I should have done a lot of ACATs, but I haven't because it's mostly night shifts. So I think the long day would be better.
Long day is like the weekend. Weekend long day.
But it's not me in the night. I think lots of nights in this road, like 14 nights, and next road I'm starting with night as well. That's mean I'm doing two rounds of nights. So
I think you have time to catch up.
yeah, I hope so.
So you need I think 4 gets in a year, isn't it? So but then And if we can distribute evenly over the year, that'll be better. So another thing is, around about February time, the itinerary will ask you as well as us to do the midpoint review, and it is something called.
Sorry, can you explain what the midpoint review is? So I don't know about it.
Not
Well, I don't know why they put it twice, because you don't know.
Because there's an interim review and there's a midpoint review. Which one is it?
interim review, yes.
Interim review is mid of the year.
Not midpoint review, interim review. So we will ask you to do the interim reviews. Interim review is basically something like a PRC. So in that review, there are so many questions, and we need to answer these questions, and look at this and find out you're on top of your training.
Is that something that we do, or is that something that the education supervisor does?
So the ideally, and it should be done by the educational supervisors, and but sometimes they will ask you to do it yourself before we meet. Because if you don't put the data by yourself, you don't know. And what have you done? Is it?
Okay. So that's the intent.
Mm.
There's a midpoint which we don't.
The midpoint review is
It's
basically
optional.
yeah. Midpoint is optional, and if you want to do midpoint review, and you can use this form, educational meeting. So the
There's a
idea
midpoint from below the interim.
is it a midpoint review, yeah. So ideally, and then you should meet with your supervisor 3 times in a rotation. So one is at this beginning, and the other one is at the end, and the midpoint you can also meet.
Okay.
Yeah. Is that right, Mo?
Yeah, it's true. Yeah.
Okay, so
with the next rotation, you're supposed to meet with your current supervisor and your new one.
Educational and clinical, I think.
your educational supervisor will be the same for the whole year.
Then have to
isn't it?
meet with
But
the
then
clinical
you need to meet with your new clinical supervisor. So you're rotating respiratory.
Gastro.
Yeah. So currently in respiratory,
Respiratory, yeah.
isn't it? So going to gastro, and the last one is
Geriatric.
healthy.
And then we open another induction appraisal form
Yes.
Yes, with the clinical.
with the clinical.
Okay, makes sense.
So the educational, they open the same form?
Educational supervisor also has to do the pre-induction appraisal
Is it?
for 3 rotations. Yes.
Okay, so he'll do 3 of these, and then the clinical
Yeah.
will do these.
So whatever the supervisor, whether it is a clinical or educational, and all supervisors should do 3 induction forms for a trainee, as well as the 3 end of attachment.
Okay.
So, and then with regards to clinical supervisor report, and these 3 will be from 3 different consultants. But for educational report, it is from the same consultant, but they have to do 3 different forms.
So for the first rotation, it's the same consultant.
Yeah.
Do we have to open that form twice?
Oh, no.
No, just
So if it is the same consultant, and the same consultant doing the both educational and clinical supervision, and the one form is enough.
okay.
Okay. So yeah, for your ACAT, I think, and you can use that, we can all go.
Yeah, I hope to manage next week. I missed this one because I had to go with the leave.
I think Shima has got a few, isn't it?
Can we do it, Dr. Htwe, again, like during ward rounds to see patient by ourselves?
You can also do that, and if the consultant who is going to do your report is happy.
When I was in QMC, most of the days, not all the week, it's according to specialty, but when I was in geriatric and respiratory, we can do the wards around ourselves. So at this point, I managed to get the CBDs and made an ACAT from the ward round. But here I work in hematology, so like it's very specialty, it's high specialty. So they don't, most of the time, most junior doctors don't allow to do the ward round either by registrar. I have to be with my consultant. So I think probably in general medical would be available just to do our ward rounds.
Mustafa, are you still there?
He's sleeping now.
Yeah. He's sleeping now.
It's fine. It's fine. I think.
Mustafa, how you manage to get the ACAT and mini cakes, things like that when you are in ITU?
Independently.
I didn't do any ACATs in ICU,
That's good.
but I did some CBDs and mini kicks.
Okay, yeah. No,
Because we don't see patients on our own in ICU, so it's difficult to do an ACAT.
yeah, Zayan is asking me, and she's in hematology at the moment, and she also has some sort of difficulty getting CBD, things like that.
Because most of them were down the middle edge, and they sometimes at the end of the day discuss it with the consultant. So, not usually as the consultant in hematology comes to do the work. So I think it's just because of hematology, and my rota pattern was a bit difficult. I tried in my last nights to do an ACAT, but even the patients that have been done post taken, it does not get to 5 patients. So it's difficult.
You can collect 5 patients from 2 days, Saturday and Sunday, and as long as if it is the same consultant. Another thing you can get a sign off is from
Estic?
and you will see 5 patients minimum. And, no doubt about that, and the consultant will be the same.
Would that count as an OPCAT or
OPCAT also you can do OPCAT. So STEC is and something like an acute admission as well as the outpatient thing is in the same. So any problem?
Thankfully, no.
Okay, so that's good.
There is an issue that I was told to actually escalate to you, but I'm not sure if I should or not. So on the nights in the past, so there was 2 doctors on in IAC. I'm not sure if anyone else has been through this. I'm pretty sure that they just involved. There was 2 doctors in IAC, and there was 3 on the ward. So I was one of the 2 doctors in IAC, and it was because it's winter now. There's a lot. So they brought the doctor from the ward to IAC. So there's 3 now. So once the shift happened, I went back to the ward. So I was on 2 on the IAC, and now I'm 2 on the ward. And on the ward, I think the F1 sees 4 wards, and the SHO IMT 1 or 2 covers 6 wards. If you do the maths, it's around 160 patients with 1 doctor covering them. It's very busy and it's very unsafe. Like from my experience from the nights that I did, there was a lot of patients that I didn't manage to get.
In your opinion, which one is busier? Is it IAC or?
Because I lived both of them. I had the experience between both of them within a week gap. IAC was extremely busy. We had some day there were 36 patients to be seen. We came in with 20 on the board not seen yet. So he's extremely busy. But then on the ward, having 1 doctor covering 160 to 180 patients is extremely unsafe. I've never wherever I worked, that was never the ratio 160 to 1 is not.
But not all 160 patients.
You don't see all of them, yes. But let's just say 10% or 5. Yeah, let's say 5%. It's still a lot. It's still 18, 20 patients.
To be fair, I done my IMT in QMC, and Ahmed will know that. We used to cover 6, 7, 8 wards in the respiratory, cover the whole respiratory ward in the city hospital, which 2 big large wards, including 30-something patients, and a lot of patients. So the baseline we used to cover in the night shift or the long day is 6, 7. But unfortunately, this goes.
I think in QMC, I haven't worked there, but would you also do the jobs like the bloods and everything?
It's the same.
Oh, wow. Okay, so my bad.
It's busy.
Because if it was just reviewing patients, I wouldn't mind that. But then you get once and do the cultures.
I have done all nights, so I have done
which takes a lot of time.
in both sides, both ways. When I done the ward when we were 3, and I done the ward when we were in both ways. And I found it's busy either way. So, but to be the ward with the 3 was definitely better than 2. The 2 gets crazy. And
what you should have done is
I think Shema has something to share.
Yeah.
Good afternoon,
everyone. Sorry. Sorry, Dr. Htwe, I'm quite late to respond to your question. I'm on annual leave and outside UK, so the connection and everything is really poor here. So to answer your question about my ACATs, luckily enough, after a lot of hard work, I managed to sign like I think 5 to 6 ACATs so far. But it required a lot of you know hard work to do. I did one OPCAT so far. And I'm still struggling a little bit with the OPCAT, to be honest. My main struggle with the OPCAT, but I have done like 5 to 6 ACATs so far.
Okay. You have a lot of private training, and then you're well ahead of other people.
Usually can borrow something.
So Ahmed is asking if you can borrow yours.
Sorry, I'm not sure if you were talking to me. The voice is a little bit muffled. As I said, the connection is really poor from my side. I don't know if this was
No,
directed to me.
we are just joking, Ahmed, and he wants to borrow some from you.
Oh, yeah, sure, please. My portfolio is all yours now.
Yeah, any question?
Not in particular, but I'm just,
Supervision, so
yeah, I'm still struggling. So I had one meeting with my educational supervisor. But after that, I didn't have any, like, I'm trying to chase him for a few things that I need to discuss because I'm behind a few things and I just want to discuss with him, what should I do? It looks like he's not replying.
I don't know.
Well, my clinical supervisors are very busy, so I know that I will chase him, but he's really busy. The Professor Shearer's like I'm doing a deputy manager and doing some administrative work.
Well,
as
my
well.
problem is he's my clinical supervisor and my education supervisor. And I can't like email him every time when I want to see him like 30 times.
So actually, he was not yours, and you know, the initially our plan is another person, but then that consultant has retired. So
Yeah.
after he knows that only you come in. Okay. Yeah. Try to. I think he's now back in the hospital, isn't he?
Yeah, he should.
Physically.
I haven't seen him, but he should be, yeah, because he told me he will be back in November.
Oh. So
But I haven't met him yet.
do you know where his office is?
No. Is it on?
So I'll show you where his office is. And so go there and you know, wait in front of his office.
Yeah.
Yeah. I know some consultants that are very busy and very difficult to get hold of them. Or if you have some other problems, and you can discuss with me as well if you want.
Okay.
Is it something to do with your education? I mean, your exams or?
Yeah. So, yeah. So whenever I see you, are you on the wards or?
I'm on the ward. Not now, but in December. Yes.
It's not something urgent, but I just need, because I don't know like what I'm struggling with my exams, and I don't know like after IMT 3 what if I don't clear my exams.
Or what happens?
What would happen next? Like things like that. There's a few things in my mind, so I wanted to ask someone to give me some idea.
Yeah. We can talk about that.
He's not the only one struggling with these.
You're not the only one.
You just finished as well, right? Last week.
Yeah, but I took part.
No, don't despair about your exams. So it's life actually. you have to come across and you have to pass the exams, and so that's not set by me and not set by anybody, and it's a requirement. And so I know it's difficult, but then at the same time you have to try. But if you're struggling, and let me know. I know business is not very easy to pass, isn't it? I know.
No, a lot of my friends passed first time, but I'm just finding it difficult.
No, it's very,
my exam technique's not very good.
no, it's very different from the person to person. You cannot compare with other people. You have to look at yourself.
Yeah. Are there any like PACEs, like mock circuits or mock exams that you do here or in Lincoln or anything?
We don't have a mock exams here. Yeah.
Okay. They did one in Nottingham, but then they stopped doing it as well.
Usually do in Nottingham, but
Yeah.
people like assigned together.
Yeah,
They choose if 2 or 3 people doing basis, so you can make a group and do together. So usually do this in Nottingham.
But if you want me to do that,
I mean, I know it's really difficult, but if there's any sort of scope to arrange that, but otherwise.
I'm not sure if there is courses for the basis.
Yeah, there is.
no, there are loads of courses.
I already done that.
Sorry.
Last time they were doing PACES teaching here.
Oh, really? Who?
When you were here, like.
Oh yeah, last time we were here. Yeah.
I think
No, that's organized by.
like Htwe, some consultants, they were doing it, I think, with some registrars. Yeah, here.
Oh.
When Sheenam, Ali guys, they were here.
No, it's not consultants.
I think it was Dr. Kazi, he was there, he arranged everything.
Oh, okay.
Maybe that was just like a one.
For all of us.
Yeah.
We don't like, even if people have, I'm still going for part 1 in jail, but if they started to do some teaching for the patients, by the time we reach the patients, all of them, because we're very small in numbers, so it's not like UMC or Lincoln large trust where lots of people can do groups. So it's just like only 6 or 7 of us. If we can do some teaching for the patients, even for the people not sitting for next time and right after, at least we get some more.
If someone picks up the QIP, that would be good. Faces teaching.
Oh.
Just doing QIP.
Yeah, our idea. Yeah, so I've created a group for the IMT, and
because we sort of like still lots of
there are quite a lot of them. Hopefully, some get shortlisted.
Well, I helped a couple of them. I helped one of them just last time and we succeeded. So yeah, there was some application. You got everyone. I encourage everyone in the department to apply for IT. So we'll have a voice. So
yeah, this is a bit incomplete now, so we can only do interview practice because the application was so early, so we missed it.
But in person, I like a lot of people always asking some advice in person.
Yeah.
I literally advise all the juniors in my department to go for it, and they did.
Yeah.
Not of course they didn't get the point because they changed the point set, which now I think has made it more difficult for.
Yeah, they changed it. They
I
changed
think they put more points on the
scoring.
master P now.
Really?
Yeah, I think there's like 8 points or something.
Really?
12, so.
No, they took the point for MOSCP or some. I think they took the point.
You sure?
No, I don't think. I think they made the point very precise to a certain point, unless you cut it. Like when you apply, there's a lot wide range you can collect your point from. But now they made the point very precise because I done the application with someone and it's literally not that.
Okay, so who's doing business at the moment? It's more.
I might take a break though. I might try in the summer. I can't go through it again. but I'm still going to practice. But I'm not going to take the exam straight away.
Practice, but don't do it straight away. But yeah, do it at some point. Maybe do.
Yeah. But I think there would be like a large appetite for PACES teaching here, even if because everyone's going to be doing it at some stage. So
that's what I was thinking. So, and I think maybe a couple of fridges as well.
Yeah, even
fridges.
fridges. Yeah.
If we've done a group for people teaching, even if we're not sitting this year or the next few months, but at least will give us more practice, and by the time we reach this.
So that's what I'm saying. I'm more than happy to help you. And so,
Yeah, sorry, Karen, sorry.
Yeah.
Karen, sorry.
Yeah, so we have to set a specific time and date. Yeah, so apparently, and I should be free on that time. And then and I'll find cases, and if I find cases, then yeah, I'll set a time and date, and after that I'll let you know. And on that day, if you're there, and
If we can make like a WhatsApp group.
Like a group,
ask
yeah.
some of the registrars who have done their cases recently with some fresh knowledge. And also if some other consultants who are willing to help us, then we
Yeah,
can just.
maybe some of the writers who have
Yeah.
done our people us bases recently, they will know how the experience and then layout and the stuff.
I think Mustafa, you want to talk something?
Yes, I was just saying, yeah, I want to practice spaces with anyone. If you're making a group, please add me. I did part 2. I'm waiting the result, so hopefully.
Have you done the exam?
Basically, all of us.
Yeah, I took part 2 on last Wednesday, so hopefully I pass.
It's not good. That's not good.
When it's played out loud, it doesn't look good. All
The
of
hard
us
truth.
need, none of us lost bases, so probably all of us need practice. So I don't think.
I think that the other IMT one, I think she might have also taken part 2.
Anna, she was taking part 2 this month. I'm not sure if she done it.
So that was last Wednesday too. Yeah, so actually 4 of us.
So I was sitting part 2 this
Oh,
month.
and I'm okay.
And it'd be good because we could share like patients on the wards that have good signs. We can do like examine this patient with this system and like it's if we had a group. So
Yeah, and yeah, I'll watch out, and if I find interesting cases, I'll use it.
Yeah.
You know I find the communications stations, the station 1 and station 3. So half of the stations, and they are very easy to pass, and we cannot fail the candidates because it's just the talking, and so we are observing and how they talk and mark. So these 2 sessions very quite easy to pass. And another communication is here on station 5. Station 5 is more like a theory and very much similar to day-to-day clinic. So again, we are not using the very difficult cases, and so the diagnosis is quite obvious. So again, it's the easy to pass. So the main thing you need to focus is the short cases, the system examination. And I find the most candidates and they find difficulty in these cases.
One's respiratory always, one's gastro, one's cardio, right?
yeah, and then 1 year,
So only those 4.
yeah. So it's those 4, and then the consultations could be anything. And there's 2 communication stations.
How many stations is it?
The 8.
Lots of stations.
Quite a lot, yeah.
Yeah.
8 is a lot.
How come it's 5 stations?
No, I saw 8 individual cases, but it's like 5. So
Oh, I see.
they group 2 together sometimes. So you do like an abdomen and respiratory together, and then cardio and neuro together, and then the rest will be like 1 each or something. But yeah, it's 8 separate cases. I've done it 3 times, so I'm pretty sure that's like there's no rest station. That's another thing. You just go straight from one station to another.
It's not like the medical school.
Yes.
Okay, so any more thing to discuss?
Yeah, I wish I started earlier. I wish I started in 91. I'd already done part 1 and part 2 by then. I should have started then. So just start now.
Okay, we can make WhatsApp group today.
Yeah.
Maybe Ahmed, maybe Mustafa Ahmed, you know, all of everybody. And if you know anyone in Raj is interested for the patients, we can add them. And probably while we're doing our acute shifts or anything, if we like Htwe are ready to help, and we find out another consultant or someone who's in Raj is ready to help as well, we can.
Another thing is that before you examine that particular case, you shouldn't know the diagnosis.
Yeah, absolutely.
So if you know the diagnosis, then
It's giving you a, it's giving
it is not the exam.
you'll know what to look for.
You just say patient XYZ for this examination, cardio issue,
Yeah.
and that's it. Something.
So the patient on a bed number something.
Yeah.
And this patient is good for abdomen examination or something like that. Yeah. So don't put any sign or nothing. And then if you approach the patient again, and then you know nothing, nothing about the patient. And that'll create a real exam scenario. Otherwise, if you know the patient and if you know the sign,
I've got patient.
Oh, do you?
Yeah. Respiratory.
Oh, do you?
3C, 4C.
4C.
Day 4C. He's young as well. He's 30. He's 30-year-old, so he's more. He'll be more than happy for you to talk.
Oh, great. 4C, you say?
4C, yeah. Young one as well. There you go.
Thank you.
okay, so anything you want to add, Shema and Mustafa?
Thank you, Dr. Htwe. No, thank you.
Okay. Are you babysitting?
I was, but now she told me.
Okay, so
Thank you.
so we'll again maybe 2 months later. And but if you have any problem, just